So let me ask you a question. Have you ever wondered how medical innovations are brought into actual patient care? How do we take it, something that's out there, and how do we safely bring it into the hospital? Well, I'd like to introduce a video that we're going to share about El Camino's Heart and Vascular Institute. In that institute, we have physician leaders, we have advanced practice nurses and data specialists who work together to bring promising technologies to you, the patient. Let's see how they do it. What's the process? Let's watch the video.
At El Camino Health's Heart and Vascular Institute, innovation isn't a destination, it's a cycle. Guided by clinical leadership, powered by data, and delivered through expert teams, we continuously elevate cardiovascular care for every patient.
We start with innovation, introducing new services and quality improvements that transform care and enhance the patient experience.
Every change is validated against best practice standards, aligning care with evidence and patient safety.
From evidence to everyday practice, our educators and operations leaders turn guidance into action.
We document all the care, benchmarking our quality using national registries.
Quality care drives decisions. We track outcomes in real time and use data to refine care quickly.
With outcomes in hand, teams identify opportunities, prioritizing changes that deliver the greatest benefit to patients.
At HVI, innovation is continuous, driven by leadership, implemented by expert teams, measured with precision, and focused on what matters most: better outcomes and better experiences for every patient.
I'm so grateful to be able to bring you behind the scenes and show you some of the teammates you probably saw at the event. We have an incredible team of caring physicians, advanced practice nurses, and data specialists, and they bring these life-changing advances to the community. One of the most exciting advancements recently has been in the field of electrophysiology. You know, Dr. Ramahan talked about the electricians. Their field is very fascinating and has been undergoing significant change over the last 10 to 15 years. Recently, there's a new technology called pulse field ablation. It's a breakthrough treatment in the treatment of AFib. So we want to talk to our panel group here about the new technology and also how it was onboarded at El Camino. And so let us introduce our medical director, our physician leader in the electrophysiology program, one of his colleagues, a practicing electrophysiologist, Dr. David Singh, and the program coordinator, the advanced practice nurse that takes care of the program and keeps everything together, keeps us progressing. Let's introduce them to the stage.
Well, good afternoon. I'm Shaun, the medical director of electrophysiology at El Camino Health. Sharing the stage with me is Dr. David Singh, also a cardiac electrophysiologist, and our nursing counterpart, Shaun Marriott, who serves as our electrophysiology program coordinator. Thank you for sharing your morning with us. I hope you found this program to be worth your time. We want to shift a little bit in our discussion towards some of the electrical rhythm issues that patients encounter. Dr. Singh and I, as cardiac electrophysiologists, are subspecialists of cardiology focusing on abnormalities of the cardiac conduction or electrical system. One of the most common arrhythmias that you may encounter in this field is atrial fibrillation. I call this a 1 degree of separation disease, in that if you yourself don't have atrial fibrillation, you almost certainly have a family member, a friend, or an acquaintance who does. Looking at the scope of the problem, while estimates vary, the basic understanding is that this is a widespread, obvious problem that affects tens of millions of people across the world. And therefore, increasingly, because it's a disease of aging to an extent, we're seeing, as the population ages, that we're seeing this more and more. In fact, I would say that it occupies over 50% of Dr. Singh and I's practice. The majority of patients you see in the hospital these days may be with atrial fibrillation-related diseases. So we'd like to focus our discussion today on this specific disease and also highlight some of the innovations that have developed over the last couple of decades, and particularly in the past year or two, as innovations have really accelerated. So I want to start with a question for Dr. Singh. Maybe for those who are not familiar, give us a basic understanding of what atrial fibrillation is and what types of symptoms it may present with, and when should one seek a cardiologist to discuss those problems.
Yeah, well, thanks for having me. So, you know, as Chad was saying earlier, we kind of loosely divide our field into plumbers and electricians. And the heart beats because of electricity, 100,000 times per day, every day of your life. And every time your heart beats, it's because there's an electrical impulse that starts at the top of the heart, works its way down to the bottom. And a normal heart rate, you know, hopefully for most of us, you know, sitting here in this room is probably between 60 and 80 beats per minute. Maybe mine's like 80 right now because I'm on stage. But, you know, our body is kind of miraculous in the sense that it controls our heart rate and meets our metabolic needs. When people develop atrial fibrillation, what happens is the top chambers of the heart kind of go into chaos. And instead of beating at a normal heart rate, they're beating at 400 to 500, sometimes 600 beats per minute. In fact, they're beating so fast, they're essentially not beating at all. They're just quivering. And there are a lot of downstream consequences from that problem. People can develop strokes at much higher rates. Symptoms are very common, so people can get shortness of breath. They can get chest pain. They may just feel fatigue, or they may not know it at all. And that's one of the big challenges that we face. It's very common, I think, for Dr. Cho and I to see a patient who might have gone in for a routine colonoscopy, didn't know they were an AFib, and were told, hey, by the way, you have this condition. So for better or worse, because this is such a common thing, we see a lot of this AFib, and we'll probably end up seeing a lot more of it as time goes on.
For many patients who may have some of these symptoms, what is the point that they should possibly see an electrophysiologist? How does that decision making happen?
Yeah, I think the main thing I tell patients is just don't ignore it. And you know, doctors are the worst patients. Actually, I have to tell my doctor colleagues not to ignore their symptoms because sometimes we just downplay things. But you know, I mean, look, everybody kind of knows what your baseline is, right? So if you're feeling normal, and then you might notice over the course of a month or weeks, or sometimes it's even more acute, that you're not feeling that great. You might feel more fatigued. You might notice if you're climbing the stairs in your house that it's just a little bit tougher. You might feel your heart racing. You know, some people feel their heart start to race. I would just say don't ignore it. And so the first step would be to see your cardiologist. Now, the really, you know, amazing thing about our field is that we've been impacted significantly by things like Apple Watches and Fitbits and Oura rings. I had one patient come in with 4 different rings on each finger the other day, and I was like, this might be overkill. But actually, it's quite useful from our standpoint because it's allowing us to get data on patients where we really didn't have access to that kind of data before. So it gives our ability to detect this stuff a little bit more objective. So to answer the question, I think if you just don't feel right, if something feels off, don't ignore it. See your cardiologist and ultimately an electrophysiologist if it's appropriate.
I think that's a great point. Your cardiac rhythm is something, obviously, that's been beating from the moment you were born, something we all very used to taking for granted and not really thinking about. When it does start causing notice, that's when you should definitely consider talking first, maybe to your primary care, and then through very simple tests, we can identify pretty quickly whether there's an issue here. And these wearables have only accelerated that and have been a real tool in terms of our ability to make these diagnoses. So once you are diagnosed with atrial fibrillation, and perhaps you've seen a cardiologist, maybe even an electrophysiologist, at what point should one consider an advanced strategy such as an ablation, and what exactly does that mean?
It's a great question, and I think that's the question that we, as electrophysiologists, really deal with on a daily basis. The central question, if a patient comes to us with AFib, is do we need to do anything about it? And to be honest with you, 20 years ago, 30 years ago, we had very limited options in terms of how to treat AFib. Now, today, there are a whole multitude of different strategies, the most common being ablation, which many of you have heard about. And what's really amazing about being in this space right now is the technology is literally changing from year to year. The central question for anybody with AFib is it damaging your heart? And that's our job to work with you as the patient to make that determination. And do you have symptoms? If you have symptoms and it's affecting your quality of life, then what we want to do is try to restore your heart to a normal rhythm to make you feel better. The third thing, and the third and really important pillar of AFib management, is reducing your risk of stroke. Unfortunately, for some people, their first presenting symptom of AFib can be a massive stroke, and that's always potentially a real disaster. So we want to try and recognize it earlier. But for anybody with atrial fibrillation, one of the things we always focus on is how do we reduce your risk of stroke, because it can be such a devastating consequence from the disease.
And after we've addressed those pillars that you've described, and a patient either is not responding to therapy or continues to have symptoms, oftentimes we suggest that an ablation may be an appropriate step. So what exactly is an ablation? And can you kind of outline specifically what that means for the treatment of atrial fibrillation?
Yeah, so ablation is basically a tool that we have, and our use of this tool as the technology has improved, we've become more and more reliant on it. It's become safer, it's become more efficient, and we'll talk a little bit about PFA, but it's become really kind of a game changer in our ability to treat AFib. The basic idea with AFib is that there are areas of the heart that are triggering the AFib, that are causing the AFib to come to life. And we know where those areas are in the heart. And ablation technology is actually just us going inside the heart. Just like Chad, we don't cut people open. I don't use scalpels for this procedure. We get in through using veins in the leg. We go target the areas in the heart that are causing the AFib, and using a tool like an ablation catheter, we're basically inactivating that tissue. We're essentially killing it, creating a small, very controlled area of scar. One basic principle in electrophysiology is muscle conducts electricity, scar cannot. So if we target very carefully just the areas that are causing the AFib and inactivate them, the hope is, and usually the result is, that the AFib goes away.
And you can see from the graphic that's on the board now that this has been an evolution. The earliest studies suggesting that you could affect AFib with this technique dates back to the late 1990s. Over that time, through innovation, technological breakthroughs, research, this procedure has evolved and developed to improve efficacy as well as safety over those years. One of those most recent developments is what's called pulse field ablation. And can you, David, maybe tell us a little bit about what that means in the field of ablation, how it differs from some of the other techniques that maybe we've been using, and why might it be better?
Yeah. So yeah, most of us in this field are very excited about pulse field ablation. And we were just talking about medical innovation. One of the neat things about this innovation is it's actually a technology that's been around for quite some time. It was used in the oncology world before being adapted for cardiology. It's used in French fries, if anybody of you are interested to know this. French fry trivia, they use it to make the potatoes more taste better, I guess. I'm not suggesting you eat French fries, it's a heart forum, but I digress. In any case, basically the name of the game for ablation is how do we kill the tissue, right? Now, if you're killing tissue, we want to be very specific and measured about what we're inactivating. One of the problems with some of the other technologies that we have used in the past that Dr. Cho has up here, we can use heat, right? We can cook the tissue, we can freeze it, there were lasers, ultrasound. One of the big limitations for these technologies is collateral damage, right? So the heart's next to all these other structures that are very vital to just normal bodily function. And in rare cases, if you damage structures adjacent to the heart, there can be very serious consequences. One of the nice things about PFA, and why we really are excited about it, is it's highly tissue selective, meaning that you're very unlikely to damage structures other than the heart. So it gives us a much more precise tool that allows us to target the regions that we want. It's also a lot faster, right? So I think when I started doing this in 2011, I mean, if it took 6 hours to do a case, it wouldn't be, unusual. And that was not great really for the patient to be under for that long. It wasn't great for my back or my mood at the end of the day, quite frankly. Now, and again, not compromising anything related to efficacy. If anything, it may be better and safer. A straightforward case can be 45 minutes. So we're sending patients home the same day, the recovery is better, and we think that because of this tissue selectivity, it's safer, and I think many of us believe it'll probably in the long run be even more effective as well as a therapy.
And I think that's something that we're all encouraged about. The immediate benefits, I think all of us are excited about. I think ultimately this may be a better way to do it.
Yeah.
From a patient perspective side, Shaun, I think you've seen this evolve as well from that perspective. A lot of times we're focused on the procedure itself and the patient rolls out of the room. And we look at a lot of the technical aspects, but I know that you focus a lot on the patient experience. What have you observed, say, over the last 10 years that we've been really growing our AFib ablation program here, and over the last maybe year and a half that we've introduced PFA? Any big changes from the patient side?
Yes. So thank you, Dr. Cho. We actually have observed some enhancements in the care of our patients following pulse field ablation, but also from other aspects of care. So with pulse field ablation, what we've observed is that many of our patients post-procedure have minimal or no inflammatory types of discomfort, such as esophageal irritation or chest pain known as pericarditis. And also, we've been able to, in recent years, the electrophysiologists have started using closure devices to close the hole of the puncture sites at the groin veins where they feed the ablation catheters. And so with these closure devices, we've had less instances of bleeding at the groin site. And this has allowed for shorter bed rest times. So bed rest times are approximately now 2 to 4 hours. They used to be up to 6 hours. So that's a big change. And following the bed rest, we're able to get our patients up and have them start walking, making sure they can walk safely and comfortably. So what this shorter bed rest means is that we can get our patients up quicker and help them avoid other types of discomfort, such as back pain or difficulty with urination.
So I think the end result has been a streamlining of the technique and the ablation procedure. That's had impact from our perspective, but from the patient perspective, I think it's basically shortened the procedure. It's made it very readily a same-day type of procedure. It's accelerated the recovery, which for most patients, we're having to hold patients back from doing activity because they're generally feeling pretty well the next day. And so we're trying to actually hold them back to let the puncture sites heal and all of that. So there has been a dramatic improvement in terms of the vantage point of the patient, which is the part that often we overlook. I don't know if there's a way to play this slide, but if not, I wanted to just show a couple of images that we can generate during these types of okay. And so basically, during the procedure, we're able to get basic information from an anatomic standpoint of the heart through these catheters that are introduced from the groin puncture portal sites, advanced up to the heart. And this allows us to create this model of your heart. In a way, I think of it as a sculptor building a sculpture, in that you're chipping away parts. In this case, we're adding parts, and then gradually this chamber comes into view and the image is created of the heart. And that allows us, the substrate, to target these sites that Dr. Singh was saying that we want to quiet and avoid those electrical stimulations. With this technology, we're able to further minimize the use of fluoroscopy, which has radiation, shortens the procedure, increases our accuracy, and minimizes damage to those collateral structures that Dr. Singh mentioned. After that, we're able to see the end result of that, and what we're seeing is that this is translating into decreased AFib episodes. We hope ultimately, and data is increasingly supporting this, that this also translates into living longer, fewer strokes, and of course, improved quality of life. So I think we're going to stop there. There's a couple of questions, I'm sure, and
that was awesome.
There. Yeah.
Thank you. It's amazing technology, and the team. So we know we are careful not to give specific advice, but someone asked this question, so we'll make it kind of generic. If a person had an AFib ablation about a year ago and it was working, but then now they have to have a follow-up ablation, has there been enough change in the technology within the last year that might make a difference?
I guess it would depend on a few factors.
Yeah.
One, this has been around for a little over a year, so I'd want to know, what was done the first time. But the short answer is yes. I mean, we know that even as good as this technology is, there are a certain percentage of patients that are going to need some, what we refer to as touch-up work. So I think, Dr. Cho, our practice is probably pretty similar. We want to get away with one ablation, but for some patients, it does require bringing them back. And if you're going to go to the trouble of doing the ablation and we don't get the result that we want initially, we'll frequently recommend going back. And because it's gotten safer and quicker and more effective, the cost, so to speak, is not such a big deal. And we'll usually recommend going back in. So I think it'd be very reasonable to do that.
Okay, great. And is there a relationship between sleep apnea and AFib or arrhythmias of the heart?
It's a well known observation that certain comorbid or coexisting health conditions seem to increase one's propensity to develop AFib. In general, the idea is that one does have that genetic hand that you're dealt at birth. That's your genetic makeup. Some of us are more predisposed to some diseases than others, but there are other conditions that definitely modulate your risk for developing atrial fibrillation. These are some of them. Sleep apnea, hypertension are the two of the most common coexisting conditions. That, I always say, along with decades of living, you mix all that together, and for some of us, unfortunately, in your 60s, 70s, typically, will develop atrial fibrillation. But these are all the observations and coexisting conditions that we know can contribute to atrial fibrillation. Sleep apnea is a big one because it's almost ubiquitous, way underdiagnosed, and for that reason, it's often one of the first steps that we recommend once someone is diagnosed with atrial fibrillation.
Get that checked out. Okay. Well, thank you very much. Wonderful panel.